Hello and welcome. Thank you for joining us for this specialty-specific recorded session for ARCP preparation related to the new curriculum that came into force in the summer of 2021. This relates to core surgery. I'm delighted that I'm joined by Michael Ho, who is a maxillofacial surgeon in Leeds and is the curriculum lead for the core surgery SAC. Michael, thank you for joining me. You're going to lead in with an introduction about the changes and what those are, and put a bit of context into the core surgery curriculum for us. So over to you.
Thank you very much, Keith, for this opportunity. In summary, the Core Surgical Training Advisory Committee has risen to the challenge of producing a new curriculum to meet the requirements of the Shape of Training Review and Excellence by Design standards for postgraduate curricula. Following considerable consultation and consideration, there remains a need for core surgical training curriculum lasting an indicative 2 years as a bridge from completion of foundation training to the beginning of surgical specialty training. This curriculum specifies those areas of knowledge and skill shared by all surgeons through its common content, describes the additional elements of learning for all core trainings attached to specific surgical teams, and facilitates the development by trainees of the requirements for competitive entry by national recruitment, or run through into at least one of the specialty programs in the 9 surgical specialties, excluding neurosurgery at ST3 level. To give a brief overview of the changes to the new core curriculum, I'll break this down to a few areas. With regard to the phases of training, the initial, intermediate, and final stages of the previous version of the surgical curriculum have been replaced with 3 phases. The new core surgical training is phase 1 of surgical training, lasting an indicative 2 years. Phases 2 and 3 lie within specialty training. In terms of the syllabus, the skill levels of the syllabus indicates levels of knowledge and clinical skills which have been removed from the old curriculum, and it's been retained at the broad higher level of outcome topic. The skill levels for technical skills are still retained. In terms of the syllabus structure, there is no change to the modular structure of the syllabus. The MRCS examination aligns to common content module. The syllabus content change has been relatively minor. There's been incorporation of a few more contemporary elements such as genomics, artificial intelligence, and robotic surgery into the basic science component. In addition, the introduction of recognition of the European trauma course or any locally provided equivalent course as a recognized trauma and resuscitation guidance course provided has been accepted, and there's been some minor ST3 preparation changes within the oral and maxillofacial surgery curriculum. Some further changes to the curriculum in basic surgical critical skills has been identified. These include the elimination of the need for a specific number of workplace-based assessments. These have been changed to fit in with the trainees' need so that indicative workplace-based assessments that are required during a placement are decided jointly together with the education supervisor at the beginning and perhaps interim meetings of the learning agreement setting. In addition, there is some mandatory skills that are required, which can be carried out through the mini-CACs or DOPS workplace-based assessment settings. There's been no change to the training pathway, and there'll be options for those trainees who demonstrate exceptionally rapid progression and acquisition of capabilities to complete training more rapidly than the current indicative 2 years. There may also be a small number of trainees who develop more slowly and will require an extension of training in line with the reference guide for postgraduate specialty training in the UK. What's been introduced in the new curriculum is the high-level outcomes. The high-level outcomes, such as capabilities in practice, have been introduced alongside the 9 generic professional capabilities. These are given equal weight in assessing trainees through the multiple consultant report. In phase 1 of training, there is a final gradation of supervision levels, where the lowest 2 supervision levels are expanded to allow more scope for the demonstration of progress and excellence by trainees following core curriculum. The supervision levels indicating consultant level practice and beyond, present in the 10 surgical specialty curricula, are not reproduced in the core curriculum to avoid unrealistic expectations of core trainees. With regard to assessments, a new assessment tool, the multiple consultant report, or more widely known as the MCR, has been introduced. There will be a reduction on the reliance of required numbers of other workplace-based assessments. And finally, with regard to courses, the JCST and its core surgery training advisory committee consider that some knowledge and capabilities are best gained in the formal setting of a taught course. These areas are listed in the new curriculum document in Appendix 4 and should be considered to complement rather than replace or obviate national, regional, and local enhanced induction or bootcamp programs and in-course teaching events. Thank you.
Thank you, Michael. That's really clear. I'm going to ask a series of questions now, just to highlight some important points that we certainly get asked by trainees in relation to ARCP preparation. The first being, what do you see as being meant by critical progression levels for the end of phase 1 related to core surgery?
Thank you very much, Keith. In terms of critical progression skills or high-level skills required for core trainees, these are largely described within the CST curriculum document on pages 12 and 13. It relates to trainees achieving the capabilities in practice in terms of managing an outpatient clinic and managing the unselected emergency take, ward rounds, or ongoing care of inpatients, operating list, and the MDT working all broadly at a level 2, which is the level where a trainee is able and trusted to act with direct supervision. There is a pre-specified range to this. Level 2A relates to when a trainee is able to complete some of the capabilities under direct supervision. Level 2B relates to when a trainee is able to complete most of the capabilities under direct supervision. And level 2C is when a trainee is able to complete all of the tasks under direct supervision. So specific to core training, they would be expected to achieve level 2C with regard to managing ward rounds and the ongoing care of inpatients. Levels 2B with regard to managing an outpatient clinic, the unselected emergency take, or an operating list. And level 2A with regard to managing multidisciplinary team working. That's very clear. And again, that reference that it's on pages 12 and 13 of the core surgery curriculum. Is there any circumstance where a trainee may have achieved those progression levels earlier within phase 1 of core surgical training, and what may be the outcome in that circumstance? Thank you very much, Keith. That's an excellent question, and in fact, it is a question that I get asked from time to time when I was the Training Program Director for Core Surgery. One very good example would be for trainees within the specialty of oral maxillofacial surgery, or those who have a career intention within such a specialty. Trainees who can demonstrate achieving the capabilities in practice levels as specified earlier at the end of their CT1 or ST1 year with the completion of the MRCS exam would therefore be eligible for direct progression onto the ST3 level, meaning that they would be considered to have achieved competencies for completion of phase 1 training within the surgical curricula.
Thank you. And on that same topic, but at the other end of the spectrum, what would be the circumstance or the effect if a trainee was not able to make the critical progression levels for the end of phase 1 training? What will the consequences or possible outcomes be?
Thanks, Keith. Again, every trainee is unique and progresses at their own level. Certainly, some trainees may require more time or perhaps more targeted support or supervision to enable them to reach the required levels of capabilities in practice for progression onto phase 2. So it does depend on at which stage the trainee is. If a trainee is perhaps switching placements and having their first learning agreement meeting with the educational supervisor, then perhaps quite clear targeted support and action points should be made at this learning agreement meeting with the use of targeted WBBAs to enable trainees to demonstrate that they have made progression towards the points of completion of phase 1. There will be some trainees who will come towards the end of their core training year 2 or ST2, where we find that there are still areas for development required, which would help them reach the level required for completion of phase 1, in which case the training program directors and assigned education supervisors should perhaps consider allocating further training time to the trainee to allow them to extend their core training for a defined period with the support of the postgraduate dean.
Thank you. That segues us quite nicely through to talking about what evidence the trainees would need to complete core surgical training and so achieve an outcome 6. I wonder if we can just talk through the evidence required.
Thanks, Keith. So there are a few things that a core trainee would need to demonstrate to have achieved to indicate completion of core training or completion of phase 1 of training. This would require the completion of the MRCS examination or the MRCS ENT examination. Trainees will also need to have completed final multiple consultant reports from each placement within all of their posts that they have undergone as core surgical trainees. This needs to be accompanied by a final trainee self-assessment within each placement as well, especially in their final year of core training. Completed learning agreements with the supplement of the multiple consultant report document would be required for each placement. It is perhaps important for the learning agreements to contain sufficient detail to document the competency of a trainee at the start of every post. And this perhaps is of high importance for the start of CT1, as trainees could come from various training backgrounds. Some would have completed foundation year 2, and some might have taken time out to do an extra foundation year 3, and we have some trainees who come from a non-foundation training background. The use or suggestion of any targeted workplace-based assessments and rationale for them should be clearly outlined within the learning agreement as well. Trainees would need to also demonstrate evidence of completion of the mandatory CACs and DOPs as demonstrated in Appendix 3 of the curriculum document, and a multi-source feedback which has been completed would be required for each whole-time equivalent training year completed. Trainees would also need to ensure that their logbooks are up to date and their ISCP portfolios are contemporaneous, and there is evidence of in-date certification through an approved trauma course. These could be in the form of the ATLS course, an European trauma course, or a locally approved equivalent trauma course.
Thank you, Michael. That's really clear. And to reiterate further, I'm just going to go over a couple of those aspects again. So how would the trainees demonstrate the evidence required as they progress through the core content, the core specialty content, and also in relation to the ST3 preparation module?
Thank you very much, Keith. So most of the evidence required to demonstrate progression through the common content, core specialty, and ST3 preparation modules of core training has been detailed in Appendix 2 of the core surgical curricular document. In summary, the common content is in line with the MRCS syllabus. So all trainees within a core surgical training post would be expected to and understandably be familiar with the common content required for the exam. Within each specialty that the trainee rotates through over the course of their core surgical training, there will be core specialty specific modules which trainees would be expected and supported to be exposed to and gain competencies in. As trainees, especially those who are in uncoupled core training programs, progress through towards the second year of their program, they would have identified a career specialty of choice, and they would be strongly advised to be familiar with the ST3 preparation module contents, which can be found on pages 58 to 69 of the core curriculum document, which they would hopefully be well placed to achieve within the specialty of choice when they retreat through their placements to best prepare them for ST3 applications. And they will certainly have good support from their AES or clinical supervisors to ensure that they meet these competencies. Thank you. So, in summary, for those aspects, all that we talked about related to common content, core specialty, and ST3 preparation is available for review within Appendix 2. Again, this highlights the importance of having read the curriculum, and for those that have forgotten, that curriculum is accessible from the carousel on the front sheet, front page of the ISCP. We don't even have to log it in. So now, I think when talking about critical skill levels, the indicative critical skill levels within core, we're going to be highlighting evidence that's within Appendix 3 of the curriculum. So, Michael, can I ask what is meant by the indicative critical skill levels related to CECs and DOPs as set out in the core curriculum? Thank you very much, Keith. So these should all be very achievable. There is perhaps a need for assessment by different trainers to ensure that trainees get the broadest and the widest feedback possible within the multidisciplinary team and from different experience of trainers. It is not about numbers, it is about quality. And trainees who do not meet these levels will need to have their portfolio evaluated and perhaps may require areas of targeted support or training moving forward. These may require added training time in trainees coming towards the end of their training program to ensure that they meet the levels specified. As mentioned, these are all detailed within Appendix 3 of the ISCP curriculum. However, briefly, they involve competencies such as taking a tailored history and performing a relevant examination in an outpatient clinic. Trainees are required to complete 3 CAXs and achieve a level performance 2 in these. Trainees are required to take a tailored history and perform relevant examination for an acutely unwell patient. And trainees are required to do 3 CAXs and also meet a level of performance 2. Competencies such as effective hand washing, gloving, and gowning can be achieved through doing 3 DOPS. And trainees would be required to meet a level 4 competency in these. And in areas such as accurate and effective safe administration of local anesthetic, preparation and maintenance of an aseptic field, incision of skin and subcutaneous tissue, and their subsequent closure. All these different skills require completion by 3 DOPS in each of these sections, and trainees are required to all meet a level performance 3. And finally, in terms of completion of a WHO checklist, timeout and sign out, these can be achieved by completing 3 DOPS procedures, and trainees would need to reach a level performance 3 for these. Although there are indicative numbers attached to each of these, it is important that these workplace-based assessments or skills achievement should be used formatively to develop trainees in their training, and the stress is once again on the quality of the process rather than the quantity itself.
Thank you. So there is an indicative number of 18 DOPS and of 6 CECs that make up the indicative critical skill level for CECs and DOPS within the core curriculum, and reiterate there is a variation in the skill levels dependent on the competency required, and that they all are available in Appendix 3 of the curriculum. Just a little earlier, Michael, you mentioned about the courses that would count towards the completion of core surgical training and the possibility of the flexibility related to course provider. I know for certain courses, trainees are concerned about their availability before their pending ARCPs. So could I just ask you to discuss any of the courses that you think would be relevant to the trainee?
Thank you very much, Keith. So the main course perhaps that trainees would need to complete would be a trauma and resuscitation course, and the most established course, as most of us would be familiar with, is the Advanced Trauma Life Support course. There has been some flexibility in that the European trauma course has been recognized to provide equally a good framework in terms of trauma resuscitation training competencies, which has been recognized, and more recently, perhaps any equivalent locally provided course with clear objectives and outlines stipulated meeting the requirements of the ATLS or the European Trauma course would be acceptable as well. The APLS is a course that's been recognized for trauma and resuscitation for the pediatric group of patients. And although not mandatory, the care of the critically ill surgical patient course is a course that we highly recommend to core surgical trainees. It's been highly beneficial, and we have heard from trainees in various regions that getting a place on such a course can be challenging at times. Therefore, any local or regionally provided equivalent CRISP course with very clear learning objectives and outlines stipulated to match those of the CRISP course would also be recognized as well.
Thank you. And all of those courses and discussions related to the courses are available in Appendix 4 of the curriculum. So I hope now, Michael, we've got to the point where we've covered many of the questions and concerns that the trainees may have about their pending ARCPs, and will make it easier for them to prepare. This specialty specific recorded session will be joined by a generic recorded session that I would have done related to the preparation for ARCPs to cover the aspects concerned about the MCR and other changes from the new 2021 curriculum that are common to all specialties, inclusive of core. So thank you very much for your time this afternoon, and to the trainees watching, I hope you found this helpful. Thank you.
Thank you, Keith.